We're fortunate today to have Dr. Cawood come and speak to us. Dr. Cawood is a director of the Pulmonary Vascular Department, which does focus, he and his staff, they just focus on pulmonary hypertension. Many lectures, one time he canceled an appointment because he was lecturing in Nice. Another time he was in Beijing. It's been called the Grand Poobah of pulmonary medicine, but I always thought Grand Poobahs were guys that are much older, but no. Dr. Cawood.
Thank you. An introduction which is clearly too generous in a variety of ways. It's really nice to be here. I really appreciate the invitation and the food and everybody for coming. I'm going to talk today about the search for a cure in pulmonary hypertension, and there's really two sections to the talk, maybe three sections. The first is going to be about the center in which I work, because the reason I went into this field, the reason I specialize in pulmonary hypertension, really started in 1969 at Penn, and we'll talk about that. So there's really a long legacy of research and taking care of patients with pulmonary hypertension at Penn. And so a great part of who I am and what I've done and what I do now is really predicated on, the shoulders of people who've done this for decades before. So we'll talk about that. We'll then talk about some of the studies we've done to try to get to the cure of pulmonary hypertension. Clearly, we're not there yet, because when we get there, we're not going to probably need a PHA at that point if we can actually find a cure. And I'll show you some of the efforts we've made in terms of clinical trials and other things to try to get there. And then the last part, and probably the longest part of the session, will be questions and answers. So I want to make this informal during the presentation, but also at the end, I want to give you an opportunity to ask me any questions you have. And we can talk about different treatments for pulmonary hypertension, what exists now, what's coming down the pike, other things about research in the field, and really it'll be an open forum. So let's see. Okay. So the history of pulmonary hypertension at Penn. And it really starts, as I said, in 1969. The program in which I work, of which I direct, was started by Alfred P. Fishman. So Al Fishman is really a giant in the field. I mean, he's really one of the most prominent people in pulmonary vascular disease, and he's probably the reason that you all have the therapies available that you do, and I'll explain why he's such a key player in this. So he was the director of the cardiovascular pulmonary division, actually came from Chicago, and really opened our clinic. As a trainee, when he was a fellow, he was actually part of Nobel Prize-winning work where right heart catheterization was first done in humans. So this was done by Cornon and Richards in the 1950s up at Bellevue Hospital in New York City. Bellevue was actually part of Columbia at that time. And Cornon and Richards shared the Nobel Prize for pioneering catheterization. So most, if not all, patients who have pulmonary hypertension, folks in this room, have all had a catheterization. And this is the guy that was involved in pioneering and innovating the technique. So Al Fishman did this important work as a fellow, and even as an associate professor and full professor, he was still very important to the field. So this is a document from 1981. This is the document that talked about the patient registry for the characterization of primary pulmonary hypertension. So this is the former name of pulmonary arterial hypertension. It used to be called PPH. And because of Al Fishman's efforts directly with the NIH, over several years, they eventually issued this request for centers to do this large multi-center study of pulmonary hypertension. This had never been done before. So PPH wasn't even on the map. Starting in 1981, that all changed. And again, Al Fishman was key to starting the study. And this was really the first and one of the only large multi-center studies of this disease in the United States, sponsored by the NIH. So let's talk about some other history. So I don't know if anybody recognizes this. This is Pathlight, right? This is the PHA letter for patients. This is the first one, Volume 1, Number 1, May 1990. And it announced Pathlight arrives. This was the first time this was published. And what was in Pathlight was an announcement for an establishment of a foundation supporting research in pulmonary hypertension founded at Penn. So, and I don't know if you can read this, in late 1984, Mimi Hansel, who was a mother of three, she was a patient, organized this Foundation for Pulmonary Hypertension with her husband to promote research in primary pulmonary hypertension. Now, of course, this is 1984. There were no treatments for pulmonary hypertension at this time, and she unfortunately died in 1985 with three young children. That being said, this foundation, this research fund, still exists at Penn. So this is by far the first and the longest-standing research fund for donations to support research at Penn, and like I said, it still does that. And I've actually corresponded with Stephen Hansel, her husband, recently. So another kind of first at Penn.
This is the current pathway. How thick?
That's a really good point. This was a piece of paper. So it kind of shows how far we have all come. So Al Fishman really started these efforts at Penn, the Research Foundation, the clinical program. And in 1984, Harold Palevsky, who was a resident and fellow at Penn, then took over the program from Al Fishman. So this is Harold today. This is Harold back in the day. You can see him back there. Really not much has changed. Right. I mean, some of you are patients of his, I think, in this room, yeah. So in 1984, became clinical director. And so really, Al Fishman handed down to Harold all of this knowledge and all of the clinical experience. So I came along as an intern in 1995. I'll tell you that in 1995, when I came to Penn, I was in the primary care program. I was supposed to be a primary general internist. And after my first 3 or 6 months in the hospital, I rotated through the ICU, and the ICU is where we used to do the catheterizations for patients with pulmonary hypertension. And I saw a young woman come in who had a catheterization, and it's a disease I'd never heard of, a disease I'd never seen before, and it seemed that not many people other than people at Penn knew much about it, and I became totally fascinated and hooked. And so I switched from being my destiny from being a primary care internist to being a highly subspecialized pulmonologist. So I did a pulmonary fellowship to do pulmonary hypertension, and then did a master's degree as well. As Duncan mentioned, in 2001, I went off to Columbia to work with Robin Barst, and then actually came back to Penn in 2008 and became the director of the overall program, established a research program in 2008, and then we've had 2 or 3 new doctors join us since then. So Jason Fritz and Akaya Smith. Jason came from Case Western, Akaya Smith from Harvard, who both do pulmonary hypertension. And then we're going to have a cardiology fellow, Anjali Vaidya, join us in July of 2013. So lots of growth. So this is the overall organization of our hospital. And all the folks listed on this slide are dedicated to taking care of patients with pulmonary hypertension. So at Penn Presbyterian is Harold Palevsky, the medical director. Akaya and Anjali are medical directors at HUP. We have nurse practitioners who, of course, are very dedicated to our patients, as well as other clinicians in the program. We also have a very well-established research program. So we have Mamta Patel, who's a nurse, plus a variety of other postgrads who all just do research on patients with pulmonary hypertension. And then finally, we have another initiative at Penn, which is called the PHBI Cell Core. So this is a multi-center study where lungs taken out of patients who are having lung transplant for pulmonary hypertension are collected, and we are saving cells from those lungs. So it's very difficult to get cells from lungs of patients, right? Nobody wants an invasive procedure. We don't do lung biopsies. But when patients go for lung transplant, their entire lungs get taken out. And most commonly, those lungs, nothing is done with them. But because of this research effort, we're actually getting the lungs and saving the cells from the vessels. And so we have over 7,000 vials of cells of lungs from patients with pulmonary hypertension in our. So the lungs are shipped overnight. They're put on ice. They're processed immediately, shipped overnight. We process them the next day. We actually scrape some of the cells off of the vessels. It's actually very tedious work. The vessels are tiny. And then we grow the cells. And once they're a certain level of growth, we can freeze them down, and they can stay frozen for a very, very, very long time. So they stay frozen, and then when investigators want to do research on these cells, we can defrost them and send them to them. So, and we'll talk a little more about that. So I see our program as having a variety of missions. And really every tertiary care center in terms of pulmonary hypertension, pulmonary vascular disease should really have these same missions. And we'll talk about each in detail. The first and the most important, and really the foundation, it's at the bottom, is the clinical care of patients. Right? Unless we take good care of patients, the rest of it doesn't matter. So this is our primary responsibility. On top of that, we also do research, and we'll talk about that in detail. It's our obligation to have training and education. I'm only here standing before you because Harold Plefsky trained me, and Al Fishman trained him. So without this training mission, none of this can happen, and we can't produce other doctors who know how to take care of patients. And then it's really important to have community awareness and patient and family support. So let's talk about the clinical care, at least at Penn. So as I mentioned, we have 6 physicians, 2 nurse practitioners who really just focus on seeing patients with pulmonary vascular disease and pulmonary hypertension. We, of course, at Penn have a variety of other people involved. So we not only have pulmonologists, we also have cardiologists. And, of course, a lot of forms of pulmonary hypertension can occur with other diseases of the body. So rheumatologists are important because scleroderma is a common cause of pulmonary hypertension, rheumatoid arthritis, lupus. Hepatologists, these are liver doctors. They're important because liver disease can be associated with pulmonary hypertension. And of course, nurses, surgeons, radiologists, pathologists, geneticists, all these people are important because patients with pulmonary hypertension are complicated. You all know that. They're never straightforward. At our program, of course, we offer all available therapies, including lung transplantation, for people where the therapies don't succeed. What about the research mission? So we have multiple ongoing NIH and industry studies of new treatments. We also have basic science funded in pulmonary hypertension. As I mentioned before, we have a biobank that has over 7,000 vials of lung cells from patients with pulmonary hypertension gathered throughout the U.S. since 2006. So I should mention this has been going on for about 7 years. So these are cells from patients all over the country. And the reason that we kind of go so far and wide is that lung transplantation is less common these days than it used to be. Because we have treatments that are successful, much less of our patients need a lung transplant, and so that gives us less opportunity to get these important cells. We've actually published over 100 scientific papers on pulmonary hypertension since 2008, and we've held 5 NIH grants. So we're very active in terms of research. These are some published or ongoing research projects, and I'm going to talk about a lot of these in detail. We've done clinical trials of aspirin and simvastatin. We've looked at genetic factors in pulmonary hypertension. We have an ongoing clinical trial of a breast cancer therapy for pulmonary hypertension and studies of the right ventricle as well. And I said, we'll talk about this in detail. I mentioned training and education. This is very important. We have a formal curriculum for fellows, and every pulmonary fellow does a pulmonary hypertension rotation. So they come and spend several weeks with us in the clinic and in the hospital seeing patients with PH. We also have other research mentees pursuing master degrees. And again, we've got this nice track record of producing clinical and academic professionals. I think the success of our training is how many young physicians or young PH physicians we can produce. And we've produced a handful. And then every other year, we have something which I started called the Fishman Symposium. So this was a symposium really for community physicians, so people from Scranton and all over the tri-state area, to come and hear about different topics in pulmonary hypertension. And we bring in speakers from all over the country. The nice thing about the symposium is for the first one, Dr. Fishman was actually still alive. He unfortunately passed away a few years ago, and he actually attended with his entire family. So that was a really a special event. We talked about community awareness and patient support. You all know how it feels to tell people that you have pulmonary hypertension. Most people have never heard of it, right? And they think you said hypertension, right? They said, no, this is different from hypertension. It's pulmonary hypertension. So we have monthly support group. It's a combined support group at Penn for patients and their families. We have parties around the holiday. We do PH Jeopardy to help people get more knowledge on pulmonary hypertension. Of course, regional support groups and clinician talks like we're doing today. And then there's even, through the PHA, I believe there's webinars for patient education. So I've kind of painted a picture of what our program does and what we're about, but we do face challenges and opportunities. I don't think it's any secret that there's decreased federal funding for research. And really the sequestration that just went into effect a few months ago caused dramatic reductions in NIH spending. So part of the sequestration that our government passed reduced NIH budget. So about 10% of the money for all of our current research grants just eliminated, gone. So we're getting $9 out of $10 that we're supposed to get to do research in pulmonary hypertension and other diseases. Also, because there's very little money, the NIH only funds 1 in 10 grants submitted. So by odds, I have to get 10 grants in order to get 1 funded if I want to do research on pulmonary hypertension. This is very challenging. Of course, industry, pharma, drug companies have not been immune to such cuts. So there's decreasing industry funding for research and education. And there's also increasingly stringent conflict of interest policies that really need to separate funding from industry, from academia, and from patients and clinicians. And I think a lot of those rules and regulations are necessary. But again, it's another challenge. And I think most importantly is lack of awareness of the condition. When we send grants to the NIH, the doctors reading those grants most likely have never seen a patient with pulmonary hypertension. Right? These are general cardiologists or other kinds of researchers, and they're making judgments about which grants to fund. And sometimes it's hard because I don't think they appreciate the burden of the disease and what it means. So these are some of the things that we're up against. Okay, well, let's talk about some of the activities we're doing. And before we come to the present, let's talk about the past. So this is really the first modern paper defining pulmonary arterial hypertension, or as it was known, primary pulmonary hypertension. Classic paper published in 1951 by Dresdale and colleagues, and they presented 3 cases with right heart catheterization. And again, these are really the first 3 cases in the modern literature. And the cases are classic and really interesting how they're described. And so case 1, GN, a 25-year-old married Czechoslovakian female, admitted to Maimonides on January 10, 1950 because of exertional weakness, dyspnea, and syncope, that's passing out, of 6 years duration. So passing out for 6 years. Case 2, MR, a 35-year-old Puerto Rican housewife, admitted for the first time to Maimonides April 17, 1950 because of pharyngitis, that's a sore throat. She was well until the delivery of their 5th child 4 years prior, and after that had dramatic shortness of breath. And then finally, case 3, a 34-year-old white housewife, also admitted to Maimonides. So what's classic about these patients? Well, they're young, and they're all women. And 2 of them are described as housewives, which I think is very quaint. That's not the way we would. That's not the description we would use in this paper currently. But this is where it all started, and these are the tracings from right heart catheterization. And I mentioned the catheterization as a sentinel event in defining this disease because, as you all know, this is defined by increased pressures in the lungs. And the only way to measure those pressures is with catheterization. And so, these are the tracings here of a pulmonary artery, 121/47. So this pulmonary artery pressure normal is around 20/10. So this is dramatically elevated. Here's another one of the other patients, pulmonary artery pressure of 75/46 with a mean of 57. So again, before right heart catheterization, we couldn't even diagnose the disease. Well, a lot has happened since 1951, and I don't need to tell the folks in this room that because I imagine most or all of you are receiving treatments for pulmonary arterial hypertension. And I can tell you that the majority of those treatments didn't exist 12 years ago. So the first drug that was effective for pulmonary arterial hypertension was IV epoprostenol, approved in 1995. This was an effective drug, continues to be one of the only life-saving drugs we have, but of course is not the optimal therapy. It requires a catheter, it requires a pump, and daily mixing. 2001 is really the beginning of the modern era of treatment for pulmonary arterial hypertension. This is really the first oral drug to have an effect on this disease, bosentan. A subcutaneous drug, treprostinil, followed in 2002. And then really, there's really been an acceleration of progress with more and more medications as the years go on and on. So, really great victories in this condition. And when I talk to my patients in the office, look, the bad news is you have pulmonary hypertension. The good news is if you had to have it, this is a good time to have it. It would have been much worse to have it back here when we had nothing available or even before epoprostenol. So we have things to offer now, which we just didn't have before. So there's a lot of drug development going on. Pharmaceutical companies are very interested in the disease. Our interest has been in studying therapies which are thought to be effective and might be effective, but which drug companies may not have interested in doing studies. So, for example, aspirin. Aspirin is a very effective drug. It's probably one of the most effective drugs we have of all of the drugs that exist in our armamentarium against human disease. It saves lives of people with heart attacks. It's good for strokes. It's good for other vascular disease. It prevents clots. It's thought that clots may be important in certain kinds of pulmonary hypertension. And as we were talking about before, we think platelets may be a bad actor, may be a culprit in pulmonary hypertension. Platelets in pulmonary hypertension get sticky. They can clog up the lungs. And as I said, it seems to work for a variety of other heart and vascular diseases. So boy, aspirin would make a lot of sense for pulmonary hypertension. So what about simvastatin? So simvastatin is one of the statins. These are the cholesterol-lowering agents. These are very common, very effective. They not only lower cholesterol, we think they work by other means to prevent heart attacks and impact on other vascular diseases. So, and once again, actually in animal studies, simvastatin was very effective at treating pulmonary hypertension in rats. Okay, well, why not try using these in patients with pulmonary hypertension? Well, that's just what we did. So this was a grant that I received while I was at Columbia, based on work that I did at Penn. So this was actually part of my master's thesis. And we hypothesized that aspirin and simvastatin would increase the 6-minute walk distance over 6 months compared to placebo in patients with pulmonary arterial hypertension. So we received an NIH grant to perform a clinical trial in patients with PAH. This was a randomized study. So we randomized patients to either placebo or active drug. And it was double-blind, and that means neither the patients nor we knew what they were getting when they were getting it. So all patients got 2 bottles of pills. One bottle was either real aspirin or an aspirin placebo, a sugar pill that looked like aspirin. And the other bottle was either real simvastatin or a sugar pill that looked like simvastatin. And so basically we were able to study 2 drugs in the same study in the same patient. So a very efficient study. And included patients at Columbia, Penn, Tufts, and Johns Hopkins. Pulmonary arterial hypertension, of course, is a rare disease. It's very hard to do a study at a single center, so it's really important to collaborate with your friends and colleagues across the country. So these are some of the data describing the patients in the study. So 32 patients were randomized to aspirin, and 33 patients were randomized to placebo. So again, we didn't know who was who until the very end of the study. And you can look at some of the descriptives, some of the features of these subjects, and they're fairly typical to a lot of folks I see sitting in the room. Average age of around 50. So as you all know, pulmonary hypertension can affect younger individuals and older individuals. Mostly female. Again, not a surprise. I'm looking around the room and I see mostly women. This tends to be a female disease. Mostly white, but also with about 20% African Americans and 10 to 20% Hispanics. And most patients had idiopathic pulmonary arterial hypertension, or formerly known as primary pulmonary hypertension. So 61% randomized to aspirin had idiopathic PAH, 42% randomized to placebo idiopathic. But there were a small number of patients with heritable or familial pulmonary hypertension, scleroderma or systemic sclerosis, congenital cardiac disease, or other problems. So again, a variety of different kinds of pulmonary hypertension. So the bottom line is we randomized some people to aspirin, some people to placebo, and aspirin did not make people walk farther. So these are the end results. This is the walk distance on the y-axis, and this is weeks, so 6, 12, and 24 weeks. We studied people over 6 months. And you can see that there was essentially no difference between the group assigned aspirin, who's shown in red, with the group that's assigned placebo, shown in blue. So really no difference in walk distance. And we looked at a variety of other biomarkers or indicators of heart function and didn't see that aspirin did anything for it. I should say this was a baby aspirin a day, so 81 milligrams. We also, again, looked at simvastatin in the same study. And simvastatin did what you would want it to do for cholesterol. So it should be very clear here that people who got placebo, their cholesterol stayed the same throughout the study. But it was very clear that people who got simvastatin it brought their cholesterol down dramatically almost immediately, and it stayed down. So simvastatin works for cholesterol in these patients. On the other hand, this is a very similar diagram to before. So this is the 6-minute walk distance. We were looking for simvastatin to increase the walk distance in these patients. And once again, if you look at patients who got simvastatin compared to patients who got placebo, really no difference. And if anything, it looked like simvastatin seemed to decrease the distance walked for some reason. So on an average of around 28 meters less compared to those who got placebo. So not only did it help, there was some question of maybe it was doing a little bit of harm to patients. So this is problematic. To give you a sense of how long this took to do, I did these preliminary studies. So we did preliminary studies of aspirin in patients with PAH in 2001, and then continued those over the early 2000s. We submitted the grant to the NIH for 2005, and the grant started in 2006. It took several years to start the study and then enroll patients, and we completed enrolling patients in 2009, analyzed the data in 2010, and the paper was published in 2011. So from start to finish, really more than 6 years to do a very small study of aspirin and simvastatin. And this is kind of average for studies in this area, where it's the patients are rare and federal funding is slim. So just to give you a sense of how long this all takes. So what's the bottom line? While it made a lot of sense that aspirin and simvastatin would be of possible benefit in pulmonary hypertension, we actually saw no difference when we gave this to patients. And this is why we do clinical trials. We not only do the clinical trials to figure out what helps, we also want to know what doesn't help and what could be harmful. Aspirin can cause bleeding. There's other side effects. And so we don't want to use drugs in people where we don't know that they work. So the question is this a failure or a victory? Well, some would say it's a failure because we tested these drugs and they didn't work. I personally don't see it that way. I think we learned a lot from this study. We realized that neither of these two drugs is effective. We shouldn't be using them to treat patients and need to look other places. And as important, this was the first NIH-funded clinical trial in pulmonary arterial hypertension ever done. The first one, even since Al Fishman. And so to me, the fact that we could pull off a clinical trial in this condition funded by the NIH, that's a big victory. And that means that the second one's going to be a little bit easier, and the third one and the fourth one.